from Sarasota Memorial and the Deb Kavanaugh Multimedia Studio, this is HealthCast, a healthy dose of information from experts you can trust.
Hi, everybody. Welcome to HealthCast. I'm Allison Gottermeyer. Thank you so much for joining us today as we talk about the diagnosis of hypertension and advancements in its treatment. Our first guest today is Dr. Ricardo Yargura. Dr. Yargura, thank you for being with us.
Well, thanks for having me.
What exactly is hypertension?
Great question. I actually tell people it's a silent killer. And normal blood pressure would be like 120/80. For most people with disease or without disease, we would say the normal would be 130/80 or less. Low blood pressure doesn't hurt. I mean, some people are symptomatic from it, but I usually tell people if you have a low blood pressure, because some come into the office saying, my blood pressure is super low, it's 100/60 or something like that, I say, you're lucky, you're going to live forever. But blood pressure is over 120/80, it starts to be abnormal. And we are grading the blood pressure now to kind of frighten people to get attention and treat it. So we go up to 140/90, but that would be stage 1 high blood pressure or stage 1 hypertension.
What causes hypertension and who is most at risk?
Okay. So about 90% of people who have high blood pressure have it because they have it. So there's some non-modifiable things that can cause high blood pressure. And one actually is right at birth, essentially. Low birth weight babies are at risk of developing blood pressure in their lifetime, probably because of some associated ways of how pre-delivery treatment was undertaken or lack of. And then as you get older, the vessels in the body start to stiffen up, and so the pressure starts to go up. Males are more likely to have high blood pressure before women up until about the age of 60, and then it equalizes. And then there's family predisposition. So if you have a first relative with high blood pressure, it's possible that you'll get it. And then ethnicity plays a role. Blacks are more likely to get high blood pressure. So that's just things that you can't modify. And then there's modifiable things, and that's generally related to lifestyle. So obesity is related to high blood pressure. Stress is related to high blood pressure. Excess alcohol consumption is associated with it. Diet, high salt. People love salt. High salt, low potassium. That's a risk for high blood pressure. So these are things that are modifiable in your lifestyle and inactivity. When you think about one particular individual and you look at the U.S. population, you start to realize that a whole bunch of stuff starts to link up together, and that's what's giving you the high blood pressure to begin with. There's about 120 million people in the U.S. with high blood pressure. About 48% of the adult population has high blood pressure.
What symptoms are most common for hypertension?
So that's what I started to say at the beginning. It's a silent killer. A lot of people don't have symptoms, and that's why it's very difficult to manage younger people. Because we're all invincible, we feel fine, we're exercising, we're doing all the things we want to do, and there's nothing that's preventing us from doing our activities. So there's really no warning about you having high blood pressure most of the time. But some people will have a headache, because they can feel pounding in their head. So sometimes they feel palpitations or pounding sensation or stressed in the body because it's elevated. If you get into a situation, we call it malignant or urgent hypertension, then that's very concerning because now you're having end organ involvement, especially what we call malignant. That's an emergency situation. That could be blurred vision, headache, chest pain, chest tightness, abdominal discomfort. But I would say probably 95% of people are not aware that their blood pressures are high. And that's a huge issue because, like I said, it's a silent killer. It affects your brain, it affects your heart, it affects your kidneys.
And that's why it's so important to have regular meetings with your PCP or a primary care provider to ensure that you're getting those kind of screenings regularly.
Yes, and and if you don't want to see a doctor, many people don't want to see doctors, you can get it at the grocery store. Sometimes have blood pressure cuffs. The pharmacies have blood pressure. So check it. That's a way that you can yourself screen it. You can buy blood pressure cuffs, and check it yourself.
How is hypertension diagnosed?
So you shouldn't diagnose it on one reading generally. So if you get one blood pressure reading, it could be a fluke. If you're upset, if you had some sort of stimulant, coffee, caffeinated products, they can raise blood pressure. So you should at least have 2 consecutive blood pressure readings, and preferably in 2 separate days. And if you have the elevated blood pressure, you probably do. It's not uncommon for patients to suggest to us that they have white coat syndrome. I'm afraid of going to the doctor. I'm anxious going to the doctor, so my blood pressures are likely to be elevated. And it's true that your pressures will go up if you're happy, if you're angry, excitable, or something like this. It'll be elevated. So we depending on what the level of the blood pressure is when we first meet you, if it's what we call accelerated hypertension, then we initiate therapy right away in terms of medication. But if your blood pressure is not super elevated, but it is elevated, then we institute lifestyle modification, which would be lose weight, exercise, try and control your stress or limit your stress levels, and avoid certain things such as salt intake.
So when should patients really be asking for that referral to the specialist?
I think that if you're on more than 3 medications and your blood pressure is not controlled, then for sure. Most people need 2 drugs, and I try and tell our patients that, there's one pill you can kill 2 birds with 1 stone, so to speak. So nobody wants to take a lot of pills. But when it comes to blood pressure, most people require 2 medications. But I think that if you're on 2 and needing a 3rd and not well controlled, then we should be seeking out other causes of the blood pressure, which sometimes leads to things that we do to help them. So there's secondary causes of high blood pressure, which 5 to 10% of the population have. 95% have standard, my blood pressure is high, and there are things that you can do with lifestyle modification and the routine drug regimen therapy or the algorithm that we use. So I think that if you're on 3 medications and your blood pressure is not controlled, you should be seeing a specialist, which could be a kidney doctor or a heart specialist, because we deal with them.
It dawned on me before we continue this conversation, and I have some of your colleagues here, I wanted to clarify for those who might be watching or listening, when we say 130/80, what are the 2 numbers that doctors are talking to us about?
So the top number is what we call a systolic blood pressure. And many years ago, a lot of people were told it was the bottom number, which is the most important, and the top number was not so important. So during even my training, or around my training, we used to tell people that normal blood pressure is 100 plus your age. Yeah, so imagine that. No, exactly. That's what we have, probably in part why we have so much stiff heart muscle, heart failure, because of poorly controlled high blood pressure for many years. It did a lot of bad things to you. So the top number and the bottom are both important, because this is how it's pulsatile blood is going through your system and supplying blood flow to your brain and to your heart and your kidneys and your stomach and so forth. But there's got to be, so it's when it's pumping forward into your area is systemic, it's systolic blood pressure. And when it's relaxing, you still have to have some blood pressure there, but it sort of drops. That compliance changes as you get older and the vessels start to stiffen. And so as you get older, we're expecting the top number to actually go up and the bottom number starts to drop off because the vessel is not compliant. It's not as compliant. And it's for that reason why, although not all the societies that look at blood pressure are in sync or in line for the guidelines or recommendations of where the blood pressure should be, they're all pretty close. But as you get older, and we use the age of 80 or older, we're allowing the top number to be higher. So if we said that upper limits of normal in stage 1 blood hypertension, stage 1, 140/90 would be not great, but okay. But for somebody who's 80, we would say it'd be 150/90 or lower is okay.
Thank you so much, Dr. Yargura. And our next guest is Dr. Jeffrey Rossi, an interventional cardiologist here. Dr. Rossi, thank you so much for joining us.
Thank you.
We just spoke to Dr. Yargura about hypertension. What are the biggest myths that you would like to address?
Regarding hypertension, I think, people think that it's okay to kind of have a blood pressure that's a little bit high in the 140s, maybe over 140s on the top, 190s on the bottom. But I think what we'd like to emphasize is that over the long term, keeping your blood pressure that high can be very detrimental. So I think people kind of brush it off when they say, oh, I was stressed that day, or there was something going on, my blood pressure is not usually that high. If you are getting readings that high, even if there's some other stuff going on, it can be an indication that you do have high blood pressure at baseline. So I think anytime we see a high blood pressure measurement, it's an indication to look into it further. It can be a sign that you have a tendency to have higher blood pressure. So while it may fluctuate, anytime you're seeing some higher readings, I wouldn't necessarily dismiss those.
So you mentioned how important it is to get that treated and not to think that just a little bit high is okay. How can hypertension affect the heart, brain, kidneys, eyes, and anything else if untreated?
Yeah, so hypertension, and it's kind of one of those things that's kind of a silent killer, and that you won't necessarily know if your blood pressure is 145 over 90. You won't feel it. You'll feel normal. Everything will be okay. But you have to understand that your body and your organs are seeing that on kind of a daily basis. And over time, over the course of years, it will start to stress out the organs. So for example, in the heart, remember your heart is a pump. So the pump is beating, and the resistance of the pump is the blood pressure. So the higher that the blood pressure is, the stronger and harder the heart has to work. So over time, what that does is kind of thicken the heart muscle. So the heart is like any other muscle. The stronger it has to work, the thicker it becomes. The problem is if the heart becomes too thick, that can lead to problems with blood flow, can even lead to some blood flow going in the wrong direction, shortness of breath, and eventually could lead to congestive heart failure. So on the heart doesn't like to be working against blood pressure that way. For the kidneys want to accept blood flow because the kidneys are filtering all the blood, and that's what you see in your urine and everything along those lines. But the kidneys are the same way, as if there's too much pressure being put on the kidneys over time, it can kind of wear the kidneys down. So you'll start to see things, what they call chronic kidney disease, where you're not able to filter the blood as well as you were when you were younger. And that can kind of actually have sort of a feedback loop, where as the kidneys get worse, the kidneys are not able to filter as much blood, so actually send a signal to the body to send more blood to increase the blood pressure, and that can start kind of a vicious cycle. Regarding the eyes, that you have a lot of blood vessels in your eyes. So again, the more pressure they see, the more strain you put on those, and it can lead to things like glaucoma. It can lead to visual changes, things along those lines. And then the brain is another organ that sees a lot of these changes. There's a lot of what they call regulation of blood flow to the brain and what we call the cerebral spinal area. And if the blood pressure is too high, that can lead to things like strokes, intracranial bleeds, things along those lines that can have obvious negative side effects.
How quickly can damage occur?
If your blood pressure is extremely high, so if the top number is called the systolic, if the top number is over 180, that can be something that you need to go to the emergency room, something you need to be concerned about. That can cause immediate side effects, immediate damage. However, if it's kind of in the more 140 to 150 range, which is what we typically see in people with chronic hypertension, it usually takes years for that to develop.
Okay, so that's why you want to get it treated early, but it's not necessarily like don't pass go straight to the ER.
Right, exactly. So it's not a medical emergency as long as you're within reasonable numbers. But again, what I think we see is someone will get a high measurement and they'll kind of brush it off and say, oh, it's not usually that high. I don't usually see numbers that high. But in my experience, if you're getting some numbers that high, you probably are kind of on the course towards developing hypertension.
Can you talk about the goal of treatment with hypertension specifically? Like is it to get the blood pressure down? Is it to reverse any damage that may have occurred? What is the main goal?
Yeah, so obviously, the most important thing is to decrease the blood pressure. And usually when somebody has high blood pressure, we'll kind of do some tests to make sure there's not another cause. Again, there are some rare causes of blood pressure going up that are not age-related. You can have some benign tumors. You can have some blockages in arteries. We tend to see these much less, but your doctor may do a workup to kind of look for those things. If you have a cause for the blood pressure, then yes, you would try to fix that. But most people, I would say over 90% of people, just have age-related hypertension. And in that situation, you're really just trying to get that number down. Now, where you want the number to be is kind of a moving target. I think most people have the number of less than 140 on the top, less than 90 on the bottom. That was the goal for a long time. That was felt to be okay. As long as you're within those parameters, you should be okay. But recently, there's been a lot of studies coming out kind of testing whether or not being more aggressive could potentially lead to greater benefits for the patient. So there's a couple large clinical trials that tested less than 130 on the top, less than 90 on the bottom. And then there was even one that came out recently that tested 120, less than 120 over 80. So really getting a strict blood pressure control. And a lot of those trials were positive, meaning that the more blood pressure control you had, the better the outcomes were, less chance you had of having a heart attack or stroke or anything along those lines. I will say that we're kind of moving towards what I would call a risk factor-based goal treatment for hypertension, in that if you have a lot of risk factors for cardiac disease beyond your blood pressure, let's say you have diabetes, let's say you have high cholesterol, let's say you had a history of a heart attack or you have a family history of heart disease, in that type of patient, we would be more strict and we say, okay, let's get that patient down to 120 over 80. If you have somebody who has no other comorbidities, the cholesterol is well controlled, no family history, maybe we would be more lenient and say, okay, that patient can have 130 over 90. So I think the direction of the field is moving towards more of a kind of risk score, trying to see who is this patient individually, how aggressive do we need to be. And then age is another thing we take into account, although I will tell you that one of the trials that came out recently was in older patients, kind of testing the idea, is it safe to bring the blood pressure way down to that 120 or over 80 range in somebody who's, let's say, 80 years old? And actually that trial did show that it was still beneficial. So age alone, I don't think is a reason not to be aggressive with the blood pressure if somebody has other risk factors or other things that are concerning from a heart or brain standpoint.
So talking a little bit about the treatment options, how do you walk patients through what their options are and what's best for them and their goals?
I mean, I think it's pretty standard. Again, we usually do a standard workup that may include some ultrasounds, may include some blood tests. And then there's pretty standard medications that we usually start with. I would say most people start with something called an ACE inhibitor or an angiotensin blocker, something you may have heard of, lisinopril or losartan. Those are typically the ones we start with. Sometimes we'll go to a beta blocker. You may have heard of something called metoprolol, things like that. And then the other thing that a lot of people respond to is a diuretic or what people know as a water pill, where something called like hydrochlorothiazide. So typically we'll start with some combination of those medications and we'll see how people respond. There are some guidelines now that say if your blood pressure is very high, if you're kind of in the 160 range, you may respond better to a combination. So a lot of doctors are now starting 2 medications at once if your blood pressure is high. I think that's probably helpful, because if you are kind of in the 160 range, it's unlikely that one medication is going to get the job done. And then typically what we'll do is we'll kind of titrate those medications up to their maximum doses. And then if at the maximum doses you're still having high blood pressure, then we'll add an additional medication.
For some of those patients who are maybe on the borderline 140, 150, who may be nervous about being diagnosed and officially and then being prescribed something, what do you want patients to know about advancements in treatment and not avoiding treatment, getting that taken care of?
Right. I think, what I would tell people is there's no shame in having hypertension. It happens to people. It just happens to people as they get older. Sometimes there's nothing you can do about it. But I think it's better to acknowledge it, know what it is, and the earlier that we address your hypertension and your risk factors, the more of an effect it's going to have on you. So, I think get a blood pressure cuff at home, measure it at home. People always ask me, how often should I measure it? You don't want to measure it all the time because that can make you kind of crazy. So I would tell people a good way to start would be 3 times a week. Measure it in the morning when you wake up, measure it at night before you go to bed, because those are typically kind of more of your baseline values, as opposed to, don't measure in the afternoon after you went for a run, don't measure it after you ate a big meal. So right when you wake up, right when you go to bed, you're kind of in your most, what I would call baseline state. So, and you're going to need to get a few measurements because it's normal for the blood pressure to fluctuate about 10 to 15 points. So you're going to want to take the average. You're going to get a bunch of measurements over the course of a few weeks, take that average. And if that average is in, the 130, 140 range, you probably will benefit in the long term from being on blood pressure medication.
And how important is that relationship that patients develop with their cardiologists and moving through their options and then maybe having to adjust medication later on and things like that?
I think it's critical because, look, the truth is a lot of these meds do have side effects and everybody responds differently. One person can tolerate one medication, another person won't. And it's hard to predict. You can look in the packet inside the medication on the internet and you'll see a million side effects. And it's hard to know who's going to have what. So, you kind of have to work with your doctor and you be honest with them about what side effects you're having. There's a lot of choices. There's a lot of options. There's a lot of different medications, a lot of different classes, and there's new treatments that are coming out as well, 2 new non-medication treatments that I know you're going to discuss later. But I think it's important that you work through all the options, be honest with the doctor about your side effects, and also, be honest with them about what blood pressure readings you're getting so that you can come to a treatment strategy that you're comfortable with, but that also is kind of getting the job done, getting your risk factors reduced.
Dr. Rossi, thank you so much. And our final guest today is Dr. Daniel Malloy, an interventional cardiologist at SMH as well. Thank you so much for being here.
Thanks for having me.
We'll get to some of the newest treatment options, but first, can you take us through a typical course of treatment for hypertension? We went through this a little bit with Dr. Rossi, but when you have a patient who's been diagnosed with hypertension, how do you typically plan out their treatment?
Sure. So, it usually starts with depending on the severity of their hypertension. If it is not as severe, then we can often start with simple dietary changes, lifestyle changes, more exercise, less salt. These are the things that we initially go for. If it is more severe, higher blood pressures, then oftentimes we'll start simply by adding medicines in addition to those dietary and lifestyle changes.
How do doctors decide which medication is right for which patient?
More often than not, it depends on the different comorbidities or other illnesses that people have when they come to us. So if they have diabetes, there's some medicines that are better. If they have heart disease, there are some medicines that are better. And based on those other illnesses or comorbidities that they bring to the table, that's how we often decide. And it's usually a combination of those medicines that ends up working.
Dr. Rossi had mentioned that sometimes patients experience side effects. Which are most common, and how should patients be addressing them?
So a number of side effects can come from these medicines. We always worry about the kidneys, the electrolytes, dehydration, especially with the diuretic type medicines. Some of the calcium channel blockers will cause swelling in the ankles, which can be very uncomfortable. But mostly the more dangerous ones are the electrolyte or kidney changes that can occur when we add these medicines or when we titrate these medicines.
So how do you work with patients to address those side effects, which can be really uncomfortable and affect their day-to-day life?
Oftentimes we try different classes of medicines. Usually this takes us through 2 to 3 or even 4 medicines sometimes before we find medicines that work for them. Or in certain cases, and this is kind of what we're talking about today, is we end up with blood pressure that's still elevated despite our best efforts with all of the medicines.
Yes, so Dr. Rossi had briefly mentioned there's now new non-medication option. Can you talk a little bit about what is now happening, what you guys are now doing here at Sarasota Memorial?
So we're talking about renal denervation, which is an old concept, and it's based on the idea that the kidneys are big players in how high blood pressure is and how blood pressure is managed throughout the body. And so conceptually, taking away the artery nerves that go to the kidneys, we're able to disrupt that feedback loop and hopefully end up with some vasodilatory effects, which in turn makes for lower blood pressures. Like I said, it's a very old concept and it's actually been done for a number of years, but it's newly revamped with this ability to do it with a smaller catheter and in a safe way rather than surgical procedures or something like that.
I mean, to that vein, obviously, for a lot of patients, they would prefer the medication over a surgical option, but now this is minimally invasive. So what does the procedure look like? What can patients expect if they're going to have renal denervation? It's
an outpatient procedure. That is to say that you are at home the morning of and you come into the outpatient area of the cath lab. The idea is that you come in, you're able to lie down. We talk to you about the procedure. The procedure goes in through the right leg artery, the femoral artery, up. We plant a catheter right next to the kidney arteries, pass a wire down into them, and then deliver this catheter, which then delivers the energy to ablate the renal nerves.
Who's a good candidate for renal denervation? Because not everyone with hypertension should have renal denervation.
That's a great point, and that's true on a lot of levels. But the people that we're looking for, the people that we want to talk to and we want them talking to us about this is people who are having high blood pressures despite our best efforts with these medicines, whether it's because they can't take them from side effects or we simply can't control their blood pressures after trying up to 3 medicines, including diuretics, to get their blood pressure under control.
Is this safe? Are there different side effects that people should be aware of? We spoke about the side effects of the medicines. What side effects can you deal with renal denervation?
Well, any procedure going into an artery is always going to carry some risk. It's relatively low risk, and in the trials, they saw very few problems or complications associated with the catheters. It was mostly just access site problems, so problems at the artery, and we do our best to minimize those as much as possible. And frankly, they were quite rare in the procedure arm of the study as well.
You mentioned that it's outpatient. What does recovery look like? What does it look like when you get home?
Usually you just have to make sure that you don't do any heavy lifting for maybe 24, 48 hours. No big sports. You can't get out and golf the same day, but within 3 to 4 days, you're back to normal, hopefully with lower blood pressure.
That's got to be a great benefit to patients who have been struggling with hypertension for so long.
That's exactly the point.
What have you guys seen in the cases your team has done since you started doing it here at SMH?
So far, all 3 of us that have spoken today have been doing these cases, and we've all seen really great results, kind of actually better than what we expected. And we're hopeful as we continue to follow our patients out into the longer term that we see continued declines in their blood pressure and hopefully less medicines.
When you have to take medication, sometimes you need to switch it, you need to change dosage. Depending on what kind of surgery you're having, you sometimes have to go back in for procedures years later. Does renal denervation require follow-up care, and what does that follow-up look like?
The follow-up care is making sure to monitor and address any blood pressure problems that could occur in the future, or any changes in medicines, like hopefully decreasing medicines. But you certainly need to continue to follow up primary care doctors and probably a cardiologist to ensure that the blood pressure does remain under control.
When should a patient talk to their cardiologist about renal denervation?
Really, anytime the blood pressures are staying above 140 on the top number, when they've tried as many medicines as they can, and certainly after you've on 3 medicines, one of which usually is a diuretic, if the blood pressure is still uncontrolled, then that's the time to at least start considering renal denervation as an alternative or adjunct therapy.
Is there anything else you want to add?
I think that we've covered a lot of information about this. I think it's going to be a real boon to the people of Sarasota as long as they're able to make the trip down to the hospital, and I think that would be something that's worth it for them.
Yeah, how important is it to have these kind of options for patients in a community hospital setting? It's
extraordinary to have this kind of support from the hospital and physicians willing to take it on and take patients on to do this. And it really does add an extra alternative and extra adjunct therapy to hypertension, which is, as we've already heard today, quite a problem in the United States and worldwide.
Absolutely. Well, Dr. Malloy, thank you so much for joining us.
Hey, thank you very much for having me.
And we want to thank Dr. Yayura and Dr. Rossi for participating in this discussion as well. If you at home liked this episode of HealthCasts, please like and comment, and visit smh.com/podcast to listen to more experts talking about the health issues which matter to you. And of course, we encourage everyone in the community to visit smh.com to get the latest from Sarasota Memorial. Have a great day.